Good evening, everybody, and a warm welcome to our webinar series. The topic for today's webinar is current diagnostic approach in the diagnosis of multi-drug resistant tuberculosis. And interestingly, it has been said that almost 37% of the drug-resistant TB cases are not diagnosed, and only 31% are initiated on the right treatment. So we all understand how critical this problem is, and that is what our chief guest speaker for today is going to highlight. Can I go to the next slide, please? I am Dr. Aparna Birajdar, and I am the moderator for this session. I lead the scientific initiatives at HaystackAnalytics. HaystackAnalytics, as you all are all aware, is a startup which is incubated in IIT Mumbai and supported by the Society for Innovation and Enterprise, as well as by GE Intel. And the objective of HaystackAnalytics is spearheading innovative genomic solutions in diagnosis. So this webinar is being a collaborative effort by Haystack as well as by Thyrocare Limited. Thyrocare Limited, as you all know, is a leading service provider. It aims to provide affordable and quality diagnosis and has a separate vertical called as FocusTB, under which umbrella it provides these innovative and leading solutions. Our agenda for today's presentation is for today's webinar is a presentation by our chief guest speaker, Dr. Aparna Birajdar, followed by a presentation by our guest speaker, Dr. Chaitali Nikam. Post both the sessions, we will be having a Q&A at the end. Next slide. So to introduce Dr. Aparna Birajdar, Dr. Aparna Birajdar is a consultant pulmonologist and intensivist and bronchoscopist at Sahyadri hospitals. She has been a recipient of the Dhirubhai Ambani Award certificate and scholarship for 3 years. She's been awarded the Best Resident Doctor in March 2014 at the Lokmanya Tilak Medical College and Hospital Science, Mumbai, and has been awarded and certified by the City TB Control Center, Pimpri-Chinchwad Municipal Corporation, for exemplary contribution in the treatment of DRTB patients. Dr. Aparna, I welcome you to this webinar, and we look forward to listening from you the current diagnostic approaches, how you treat, how you manage drug-resistant TB patients. Our chief guest speaker is Dr. Chaitali Nikam. Dr. Chaitali leads the infectious disease portfolio at Thyrocare Labs, and she is a member of the Constitution of National Technical Working Group on Private Provider Engagements under the NACP. She is also the member of the National Working Technical Group on Collaboration between NTEP and corporate hospitals and laboratories, and she has authored 38 publications in peer-reviewed journals. Welcome, Dr. Chaitali. So as already indicated, just a few ground rules. We will be having our Q&A at the end of both the sessions. You could put them in your chat box and mention the speakers' names along with the question to whom you would like this question to be asked. I will be moderating and posing these questions to the respective speakers. Alternatively, you could also raise your hand if you want to ask the questions, and we will try and unmute you. We will be trying to answer all the questions, as many as possible in this session. However, if we are unable to do so due to a lack of time, we will be getting back to you through mail. So with that, I'll please request Dr. Aparna to start with her presentation.
Good evening, everyone. Am I audible?
Yes, Dr. Aparna.
Yeah. Thank you, Thyrocare, for providing this opportunity today. So today we'll be discussing what are the recent diagnostic modalities which are available to us currently in diagnosis of drug-resistant tuberculosis. We'll proceed with the presentation now. Mr. Ranjan, next slide. Yeah, so basically, the most recent guideline which is available for the management of drug-resistant tuberculosis in India is dated March 2021, and most of the references from this presentation will be from this NTP guidelines. Next slide. So, as all of you know, whether in general practice or in our specialty practices, we are coming across a huge number of drug-resistant cases. As per WHO Global TB Report of 2020, the estimated number of MDR cases in India is around 1,24,000. That is about 9.1 cases per lakh population. The first national anti-TB drug survey, drug resistance survey, it has revealed that about 28% of the TB patients were resistant to any of the drugs. In this, 22% resistance is among the new patients, while 36.82% among previously treated patients. And also 6.19% of the patients had MDR-TB, of which around 3% is amongst new patients and 11.62% among the previously treated ones. Furthermore, we are also coming across the isoniazid resistant cases, which itself acts as a driver for Rifa resistant TB. Currently, 16% in all cases are H resistant. In that, 11.6% in newly diagnosed cases and 25% in previously treated cases. Next slide, please. So that was about the India's data. I'm also working with Pune Municipal Corporation under National Urban Health Mission since last 5 years, and we are seeing an increasing number of resistant cases even in PMC limits. Now this data which I have put up here for the last year, Jan 2021 to December 2021, remember this includes only PMC limits and not the Pimpri-Chinchwad Municipal Corporation or even the rural areas. So just in PMC limits, we have come across total 300 patients who are drug resistant, out of which 101 cases were of isoniazid monoresistance and 199 cases were MDR or XDR. Next. So I'm going to first give a brief overview through this algorithm as to what exactly, how we should go about when we come across patient. Now this is the algorithm which is followed in all government TB centers, and more or less it applies in the same way to even the private practice, except for extrapulmonary where you might have to make a few modifications, which we will definitely discuss. So all presumptive TB patients or key population meaning the immunosuppressed patients like HIV, diabetes, those with chronic diseases, your clinically diagnosed and radiologically diagnosed TB patients, those who are smear positive already on ZN staining, as well as those patients who are on drug sensitive regimen but who are non-responders. So all such patients in the first instance itself, they should undergo NAT testing, which is nucleic acid amplification test, which we otherwise commercially know as CBNAT or gene expert testing. So now we will come to the right hand arm in this algorithm. If your CBNAT testing is showing either MTB detected with no rifampicin resistance, that means you have a drug sensitive patient. So you put him on drug sensitive regimen. But at the same time, you move on to the next testing, which should be sent immediately. That is FLLPA, which is first line probe assay. What exactly that is, we'll be discussing in coming slides. So basically on this line probe assay first line test, you see both rifampicin resistance as well as isoniazid resistance. Now you already know patient is rifa resistance, that will be confirmed again. And then if you get rifampicin isoniazid resistant detected, then you have to stop the drug sensitive TB regimen and then shift the patient to H mono regimen, which is for INH monoresistant cases. Also at the same time, you will do the next reflex testing, that is second line probe assay, which includes fluoroquinolone and injectable second line drugs. And also you will send a sample for liquid culture DST, which is your MGIT. It tests the resistance for moxifloxacin, pyrazinamide, linezolid, and clofazimine. Now, while the patient is on H mono regimen, if there is any additional resistance detected in this second line LP or liquid culture DST, then accordingly you will have to modify the treatment. Suppose on this regimen also you find that some patients are not responding to the treatment, then you will have to again go back and reconduct the test to establish your drug resistance. Now coming to the left hand arm of this algorithm, suppose your CBNet testing has in the first test itself shown that MTB complex is detected and you have rifa resistance which is detected. So what you do is reflexly you send the next available diagnostic test, that is first line probe assay, second line probe assay, and additionally liquid culture DST to look for sensitivity to pyrazinamide, bedaquiline, clofazimine, moxifloxacin, linezolid, and delaminid. Now, while you send this sample, what you are doing is pre-treatment evaluation of the patient, which is done for all MDR XDR cases to prevent the side effect and see eligibility for the treatment. So, in the meantime, you try to raise the reports. When the reports are available and they are showing that there is no additional resistance detected, or it's showing that isoniazid resistance is detected, but out of the two mutations, either CATG or INHA mutation is present and not both of them, and also FQ resistance is absent, that is, it is sensitive to fluoroquinolone. In such cases, you can shift the patient to shorter oral bedaquiline regimen, which is for 9 months. Now, instead, if you get H resistance detected, but with both CATG and INHA mutation, or you get an additional fluoroquinolone resistance, then accordingly the patient will go on longer oral regimen for MDR or XDR, which is again bedaquiline containing regimen for 1.5 years. During this, if you find on liquid culture DST, if any additional drug resistance is found, then accordingly you will replace the drugs. Next slide, please. So basically, this was an overview of what all we do when the patient comes to you with tuberculosis. So as we know, the effective management for drug resistant TB will rely on first detection of drug resistance and then following it by appropriate treatment regimen. Now for achieving this, genotypic testings are found to be much faster than phenotypic methods because these are not growth-based tests. So timely diagnosis, strong treatment initiation or modification is possible. Next slide. So, like we said, both genotypic and phenotypic tests are done. Out of that, nucleic acid amplification test that includes CBNet and TrueNet. CBNet, most of us are aware in private sector. We also call it Gene Expert. Apart from that, in government sector, we have something called TrueNet. Both these tests can detect rifa resistance. Next, we have come across line probe assay, which can be used for first line LPA, that is resistance to rifampicin and isoniazid, and among second line resistance to fluoroquinolone, and second line injectable drugs, that is your amikacin, capreomycin, and kanamycin. So basically, this rapid molecular tests such as NAT and LPA are your preferred method for initial detection of rifa resistance and then following resistance to fluoroquinolone and second line injectable. Now coming to phenotypic test, we most commonly use MGIT system, that is Mycobacterial Growth Indicator tube. Now this is the preferred method for drug sensitivity to many of the anti-TB drugs, and you can see the sensitivity to group A drugs like levofloxacin, moxifloxacin, bedaquiline, linezolid, group B drug like clofazimine, group C drug like delaminid, pyrazinamide, amikacin, and streptomycin. Next slide, please. So when we talk about this genotypic as well as phenotypic test, these are two methods. Genotypic tests will give you rapid molecular diagnosis of drug resistance because it detects specific genetic mutations which are associated with the drug resistance. You can use both respiratory as well as non-respiratory specimen as well as the culture isolates from your solid or liquid culture, and you can further subject them to this drug resistant testing. Amongst phenotypic, these are growth-based susceptibility testing. So there you were seeing for resistance. Here you are going to look for susceptibility, wherein the bacilli are grown, and then you test them from drug susceptibility using drug-containing and drug-free media. This is similar to what we generally do for all other antibiotic sensitivity testing also. Next slide, please. So coming to rapid molecular drug resistant testing, that is genotypic testing, like we said, the NAT, it relies on amplification of the target genetic region of MTB complex by polymerase chain reaction. So it can detect presence of TB and then resistant to further drugs like HR, fluoroquinolone and SLIDs. And this is done more quickly than your conventional culture and drug sensitivity testing. However, one drawback is that you cannot use this genotypic testing for determining the response to treatment. That is, during follow-up evaluation, you cannot determine response based on these tests. Next slide. Now coming to the CBNAT testing, that is expert MTB RIF. It's cartridge based. It detects DNA sequences which are specific for MTB complex and then detects the mutation in RNA polymerase beta, that is RPOB gene, which is associated with RIFA resistance. You can obtain the result from unprocessed sputum within a time of 90 minutes. There is minimum biohazard involved and very limited technical training is required for its operation. One requirement that this instrument requires an ambient room temperature of below 30 degrees centigrade. That means an AC setup will be required for its functioning. Next slide. Now, expert MTB XDR. This is supposed to be a follow-on test after expert MTB RIF. This is still under a process of endorsement by WHO. And once it comes, we'll be able to detect a resistance to additional drugs. We'll be seeing a further more details about this later. Next slide. Now coming to TrueNet testing. TrueNet MTB assay, which is widely available in RNTCP right now, it detects the MTB in sputum after DNA extraction. The results are available in 1 hour time. Following that, you use TrueNet MTB RIF-DX, which can be used to detect RIFA resistance. Now, the TrueLab machine, it comes in such format that it can be used at point of care. It does not require any air conditioning or a UPS to operate. So this can be used in field. Right now, most of the PHC and RNTCP TB unit centers, even in the periphery, are having TrueLab so that early diagnosis of presence of TB and RIFA resistance is possible. However, just like CBNet, if the quantity of volume of the specimens is large, like gastric lavage or your aspirates, bronchoalveolar lavage, then you have to do the centrifuging of the specimens. Next slide. Now, line probe assay, which we had discussed, it uses PCR and reverse hybridization methods, and it detects in the first line LPA, it detects mutations in the RPOB gene for R resistance and in CATG and INHA promoter gene for isoniazid resistance. Now, INHA promoter region also signifies resistance to ethionamide. In the second line probe assay, mutations in genes gyrase A, DNA gyrase A and B are detected for fluoroquinolone resistance, and RRS and EIS for second line injectable. Out of this, if EIS is present, it signifies that low level kanamycin resistance is present. Next slide. Now, the results of this line probe assay testing are interpreted based on the development or absence of wild type and mutant band. So there are 3 kinds of interpretation. When you are seeing resistance not detected, it means that all the wild type probes in the gene which is known to confer resistance are developed and none of the mutant probes are developed. When you report it as resistance inferred, that means that one or more wild type probes is not developed. So it is basically absence of one or more wild type probes and none of the mutant probes are also developed. Next slide. When it is reported as resistant detected, that means one or more mutant probes identifying the specific mutation which is conferring resistance to the drugs is developed, and this is regardless of whether wild type probes are developed or not. Also, the mutations which are associated with low level increase in MIC and associated with high level increase in MIC, they have also been identified in this test, and it aids in defining the dosing of drugs such as isoniazid and moxiflox, which can be given in higher doses in some of the regimens. Next. Now, when we talk about growth-based drug susceptibility testing, the most common phenotypic tests which we are aware of traditionally is solid culture, LJ media culture, Lowenstein-Jensen. However, it has almost been discontinued now because of the longer turnaround time. Right now, we mostly perform the Bactec MG960, which is an automated liquid culture system. It enables a higher rate of MTB isolation and requires a comparatively shorter turnaround time for growth. It uses an oxygen quencher for fluorescence detection as an index of growth. Next. So MJIT is the preferred method for DST. And again, just like LPA, this can be used for testing both pulmonary and extrapulmonary samples for sensitivity to first as well as second line anti-TB drugs. Now, advantage of this is that unlike genotypic testings, liquid culture is used to monitor the response to treatment and also long-term follow-up of patients on drug-resistant TB treatment. Next. Now, we had discussed the follow-on testing of GeneXpert, which was Expert MTB XDR. I'll just go in few details of this. This is supposed to be launched as a follow-on test after doing GeneXpert. It will detect mutations associated with isoniazid, fluoroquinolone, second-line injectable, and ethionamide all together in a single test by using, again, semi-quantitative nested PCR. The results will be available in less than 90 minutes. So the test can run on the same GeneXpert platforms using 10 color modules. Next slide. Now these 10 color modules will be compatible with all other test cartridges also. So no need to change the machine. This is currently under evaluation by WHO. And like we said, it can potentially improve the access to rapid DST testing, especially to rule out the fluoroquinolone resistance, which require in the initial stage itself before putting patient on shorter oral BDQ regimen, also in the INH mono regimen. Next slide. So like we said, this test will basically look for resistance to isoniazid, ethionamide, fluoroquinolone, and injectable SLIDs, targeting all these mentioned genetic regions, and it will do so with a greater sensitivity and specificity when we compare it with phenotypic DST. Next slide, please. So when we talk about LPA results, this is a prototype of how the results are interpreted. Most of your commercial labs will also give you a similar interpretation printed behind the report so that you can guide your clinical practice and regimen change accordingly. For example, now in rifampicin, if they have shown the mutation in target gene RPOB, if the results are written as resistance inferred or detected, that means your rifampicin is going to be ineffective. In isoniazid, if you have CATG gene, that means there is resistance to high level of isoniazid. So you cannot use isoniazid even at 900 mg dose. If you have INHA presence, that means there is resistance to low level. So here you can use H at high dosages. And this INHA region also signifies ethionamide or proteanomide resistance. Then coming to fluoroquinolones, you have gyrase A region where resistance to levoflox and low level of moxiflox is inferred or detected. That means levofloxacin is not going to be effective, but moxifloxacin could be used at higher dosing. However, this regimen has to be evaluated by putting phenotypic DST also. Also, if you have resistant to levoflox and high level moxiflox is detected, that is MUC3B, 3C and 3D, that means both your levoflox and moxifloxacin cannot be used in the regimen. Then coming to gyrase B gene, resistance to levoflox and low level moxiflox inferred or detected, that means levoflox is not going to be effective. And again for moxiflox, you have to reevaluate based on phenotypic DST. Now, in the second line injectable drugs, you can have mutation in RRS gene, where if this resistance is inferred or detected, all three second line injectables are ineffective. If you have resistance to AM inferred, mutation at 1402. That means kanamycin and capreomycin are not effective. However, the choice of amikacin should be guided by your phenotypic DST result. When you have mutation in EIS gene, that means resistance is inferred or detected. Your amikacin and kanamycin are most likely going to be effective. However, capreomycin is effective. However, kanamycin is not effective. Next slide. Now, coming to the reliability of DST in guiding our clinical judgment. As we know, effective management of drug-resistant TB definitely requires a reliable and quality-assured DST, and that is why please send samples to the labs which are certified by NTP, and they cater to a wide array of all these investigations available under one roof. Because rapid molecular testing are making it now more feasible for us to detect the resistance earliest, and so that we can take treatment decision as quickly as possible. So WHO has approved rapid molecular DST as the recommended initial test before the initiation of treatment for all TB patients. So upfront you should go for CBNet, and accordingly you should follow the algorithm. This is true for both new patients as well as patients who have been treated previously with anti-TB regimen. Next slide. Now we have discussed this, that LPA can give you detect the mutations associated with both first line and second line agents. However, currently there is no rapid molecular testing for ethambutol or pyrazinamide. But LPA can also provide information on mutation patterns, which we have seen in the previous table, based on which we can decide the dosing of drugs like isoniazid and moxifloxacin. Next slide. Now, as discussed earlier, the presence of INHA promoter region in H resistance will also tell you about the susceptibility to ethionamide. Now, apart from this molecular testing, the methods for phenotypic DST, that is on MGIT, now you have validation also done for bedaquiline, linezolid, clofazimine, pyrazinamide, and delaminate sensitivity. Next slide. However, the phenotypic DST on MGIT may be inaccurate and non-reproducible for ethambutol and ethionamide. Also, there are no agreed DST methods available for other second-line drugs like cycloserine, imipenem, cilastatin, meropenem, and PAS. Also, there is one more big disadvantage, that phenotypic DST, which is performed in MGIT, can miss a well-established RR associated mutation, and hence it cannot always be useful as a confirmatory test. To overcome this problem, WHO in Feb 2021 has published a technical report, and it is indicated that it will lower the critical concentration in MGIT from 1 microgram per ml to 0.5 microgram per ml. Next slide. This modification is expected to reduce the discordance which we get between genotypic test and phenotypic DST. However, since all these problems are existent in both uses of rapid molecular testing as well as phenotypic DST, we needed something which can be more reliable and give us a complete overview of what is really going on in the genome of MTB. So here comes the next test, which now has become available for our common usage, and that is genomic sequencing, and it should be used when reliable DST is not available. Next slide. So what exactly is genomic sequencing? Now, we know that the drug resistance in MTB is mainly conferred through mutation in the specific gene targets, which we have already seen for each individual drug. So this gives a promise for rapid diagnosis, and this targeted sequencing can be achieved through different methods: pyrosequencing, Sanger sequencing, as well as next generation sequencing, that is NGS. So you can get with NGS technology both targeted next generation sequencing, that is MTB sequence data at specific genetic locus of interest, or you can do the whole genome sequencing, that is a near complete genome of MTB complex can be provided in the sample. Next slide. So this NGS has potential for rapid diagnosis of drug-resistant TB, and it tells us about the sensitivity or resistance of almost 18 drugs when we are doing the whole genome sequencing. So basically, it overcomes the challenges which were associated with our conventional phenotypic testing, and also some of the limitations which are present with rapid molecular testing like CBNet and LPA. So in short, NGS can be used so that we can detect the genome sequence variants and predict TB drug resistance phenotypes. We can also use it for identification of strain lineage and resistance mechanism for TB surveillance, and we can recognize the genetically related strains for resolution of transmission chains. Next slide. So this is just a prototype whole genome sequencing report. Like you can see here, we had MTB detected. So this was further processed for susceptibility to the 18 drugs which are available in this testing. It includes foreign drug INH, rifampicin, ethambutol, Group A drugs like ofloxacin, moxifloxacin, Group B drug like clofazimine, Group C drugs like streptomycin, pyrazinamide, amikacin, delaminid, and also like we discussed the other drug sensitivity which are not standardized by other DST. This includes capreomycin, ethionamide, kanamycin, PAS, and protaminate. Next slide. So you get a total 18 drug sensitivity in this one single genome sequence. Next slide, please. Now, when we compare the turnaround time for this test, which is very important so that we can decide at the earliest the regimen change, since patient is deteriorating and we want to decide the next regimen as quick as possible. If you compare the traditional LJ solid culture, it used to take 3 weeks for smear positive sample for a growth to come, and around 4 to 8 weeks on an average for smear negative samples. When we came to MJIT, this time was reduced to 8 to 10 days for smear positive sample, 2 to 6 weeks for smear negative samples. But after growth, when you further go for phenotypic DST, it takes another 1 to 3 weeks from getting a positive culture. And this is indirect DST. Next slide. Now compare this with the molecular testing. Line probe assay will detect your drug resistance in 1 to 3 days on an average. CBNet will give you the testing with RIFA resistance in 2 hours. TrueNet uses 1 hour for TB detection and another hour for RIFA resistant detection. And rapid TB identification tests, which are done on solid or liquid culture growth, they will solve your problems in 15 minutes. Next slide. Now, this was all the array of tests which we subject patient to, both pulmonary and extrapulmonary samples, CBNet, line probe assays, MGIT culture, and then genomic sequencing. Now, while we are making use of all these tests, it is very important that you send your specimens in proper way. So I'm going to take last few minutes about what samples can be sent and how exactly. So coming to most common pulmonary sample, the sputum, it should be a good quality specimen with volume of at least 2 to 5 ml, preferably mucopurulent and not heavily blood stained or contaminated. So please remember, if your patient is having active hemoptysis, do not send blood stained sputum because most probably it will get rejected on your CBNet. So the patient is advised to collect this specimen in sterile container, that is 50 ml conical tube. I'm sure most of you must have seen it is called Falcon tube. And this should be done after thorough rinsing of the mouth with clean water, and just pack it in a triple layer packaging, and it should be transported to lab as soon as possible. If you are expecting that there is going to be a delay in sending, then please refrigerate it so that growth of other microorganisms is inhibited. Next slide, please. Next slide. Now that was about pulmonary sputum sample. Now coming to extrapulmonary samples. Please remember that all the extrapulmonary specimens should be collected in sterile saline with no other preservatives added. None of the TB diagnosis samples should be collected in formalin. If you want a formalin fixed sample for histopath examination, then please divide your specimen into 2 separate containers, and the extrapulmonary specimen should be sent within 4 hours to the lab, pre-inform the lab so that immediately they can put the sample for testing. Next slide. Now, extrapulmonary samples are of 2 types based on their site and mode of collection and the contamination. So you have sterile samples which are aseptically collected, like spinal fluid, pleural, pericardial, synovial, ascitic fluid. Blood, we don't encourage doing cultures for blood. Bone marrow, tissue samples, which are again very common, lymph node tissue, tissues, biopsies, as well as fine needle aspirates. Then another type is non-sterile sample, which is your gastric lavage, bronchial washings, urine, pus, and even stool samples in cases of disseminated TB in HIV infected patient and in infants. Next slide. So we'll just see some commonly sent extrapulmonary specimens. First is pleural fluid. Now, this is considered to be a suboptimal specimen, but again, pleural effusion cases are very common. Please remember that TB bacilli are not in the fluid per se, and they are mainly concentrated in pleural wall. So if you want to send the sample, the minimum volume should at least be 20-50 ml. Please do not send 5 and 10 ml and then ask the lab to do CB-NAT, LP, MGIT, everything on such a small sample. If you are doing a pleural biopsy procedure, then you can also send the fluid after that so that you have some shedding of the TB bacilli in fluid. But if you are sending a just thoracocentesis, that is pleural tapping sample, then please send a good volume. Pericardial fluid again in a similar way using ultrasound guided tapping. Next slide. Blood, like I said, it should be discouraged to send blood because you have low diagnostic yield and there is high possibility of contamination. So this is not an ideal sample for diagnosis of TB. Now, next important sample is tissue. We get tissue samples from surgical side as well as in cases of port spine. So these tissues should be collected and placed in sterile containers without again adding any preservative or fixative. It should be only in saline and maintain the temperature 4 to 15 degree during transportation and try to process it as quickly as possible. Next slide. Now swabs again are always suboptimal specimen and we do not recommend it. It also has a risk of infection for a person who is collecting the specimen, but this may be useful only in children and patients who cannot produce the sputum or swallow it. You use a sterile absorbent cotton swab, preferably early morning sample before food and drinks, and it should be placed in a container containing normal saline so that there is no drying. Mostly except for laryngeal swabs or maybe swabs from the discharging pus sinuses, we do not encourage taking of other swab samples. Next. Urine. Again, this is one of the most contaminated sample. So you have to ensure adequate cleansing of genitalia before giving the sample. Early morning sample should be collected in sterile container and it should be immediately processed or centrifuged and refrigerated once received in the laboratory. Also remember that the excretion of TB bacilli in urine is intermittent. It is not continuous. So it is advisable that you collect 3 early morning sample on different days. Next. Now coming to bronchial secretion, this is again a very common sample that you send. It should be, it can have both bronchial wash, that is direct bronchial secretion, where at least 2 to 5 ml of the secretion should be sent. If you are doing a lavage procedure where you are instilling saline, then a minimum volume of 20 to 50 ml, just like your pleural fluid, it should be a high volume. That should be sent. If you are doing the transbronchial biopsy or other biopsies like TBNA, then again collect the specimen and place them in sterile saline so that there is no drying during the transportation. Next slide. Now gastric lavage, this is a very common sample in pediatric age group because children cannot produce sputum. So aspiration of the early morning gastric content is done and used for TB diagnosis. This is done as inpatient procedure and it should be immediately transported, and processing has to be done within 4 hours because the gastric acid content will kill the TB bacilli. If you are expecting a delay, then sample should be neutralized using 1 to 2 ml of 10% soda bicarb solution. If you don't have a facility for neutralization, just label it as unprocessed, not neutralized, and the lab will do the neutralization prior to processing. Next. So just take away message, especially for extrapulmonary TB, do not collect the samples in formalin. If you want histopath, collect it separately. Send the sample earliest possible to the lab with proper aseptic precautions. Also, please remember, extrapulmonary sample when you are doing, instead of following the algorithms stepwise, since you have very precious samples, you may not be able to do the procedures again and collect the sample. Try and send all the tests upfront to a lab where all facilities are available under one roof, so that you, because this is again, there are biosafety level issues in the storage of TB samples, so you can just send it upfront so that your next direction goes immediately and you have the next test processing available readily. Next slide. Now, when you are sending high volume samples like gastric aspirate or lavage, or even BAL, pleural fluid and peritoneal fluid, like we said, centrifugation should be available. And these are all aerosol genetic procedures. Also, FNAC samples and CSF samples are very precious samples. So like I said, try to send them in one go at a lab where all the tests are available, and try to send it upfront in your first point of contact where you are doing the procedure, because later when the patient is not responding to treatment, you can give immediate directions for processing and not lose out on the precious samples. Next. So this was all from my end about what all tests are currently available and how you send them, and also listen. Thank you again, all of you, for your patient hearing. And I think Dr. Chaitali will take over from here.
Thank you, Dr. Aparna, for really a lucid presentation and a very simplistically putting across the entire diagnostic modalities. I now request Dr. Chaitali, and considering that we are our time frame is from 7 to 8, Dr. Chaitali, I please request you to proceed quickly.
Yeah, thank you, Dr. Aparna, both the Aparnas for great information, and also Dr. Aparna Bhanushali for your nice introduction. Now, I'm not taking much of the time, looking at the 10 minutes on the remaining. Maybe participants have raised their hands for this, and apologize for not displaying the video because I'm running into poor network. So, moving quickly. So, as Dr. Aparna has been already told that the regimen which has been given, and whatever the drugs and the newer drugs which are into the algorithm now. So basically, the efficacy of the patient with drug sensitive TB and lower efficiency in the patient with drug resistant TB. So these are the two most effective ways on which the MDR TB treatment success and patient survival may be associated. So basically, we need to decide which drugs should be selected and for how much long. And that's the reason there are specific time intervals also for susceptible and resistant TB. So turnaround time we are already discussed about, but just for your information, I have gathered information about patient turnaround time, which comes as a pre-lab TAT, that is a pre-analytical TAT, lab TAT, that is analytical TAT, and post-laboratory TAT. So in government scenario where in public, when it comes to getting the report for gene expert, all these turnaround times has varies badly. So these are the benchmark for the TAT, for the gene expert, line probe assays, culture and DST. So if you can see here, when it comes to on the field, the pre-analytical TAT for gene expert sample to be collected and then transported to the lab, and then lab is given information about the report processing. So basically it takes around 4 to 7 days to get the report to the patient. Whereas when it comes to line probe assay, it takes 5 to 9 days, LCDST takes 90, 29 to 58 days, almost 2 months, and then DST or any liquid culture about that, that is 15 days, 15 to 21 days more. Few of the phenotypic method by which we are processing the samples as solid culture. Now midget is the mostly used method for rapid detection as compared to solid culture. There are the molecular tests which have been already talked about. So I'm just summing up. That is a CBNAT, line probe assays, and TrueNAT. So there are some technical challenges in traditional DST, and that is because of the following reasons. So origin of resistance and interpretive criteria is not confirmed. Doses and stability of the incorporated compounds are not known. Antimicrobial activity of the incorporated drugs and interpretation result in data reporting. So these are few of the technical challenges in traditional DST, that is midget culture and DST, which has been seen. So molecular methods are less operator dependent than conventional DST. As we all know, doing culture and putting up DST in culture always requires a trained staff as compared to molecular methods, and it can be done with minimum training. Also, the sources of errors such as sample mix-up or clerical errors may be occur with both molecular and phenotypic method. I'm not saying it's 100% clear, but factors like the critical inoculum size require experienced technician to reduce the variability of the phenotypic DST method. So in general, genotypic approaches have objective and measurable parameter that can be used for QC. So if you can see about, this is a nice slide from Nikolaevsky's paper, which has been published recently. So that says that error rate varied substantially between drugs. For PZA was a consistently and most problematic drug as compared to phenotypic DST and other, and comprising 5% of all the drug susceptibility tests, followed by amikacin, ethambutol, and streptomycin, and error rate comprising for the proportion of incorrect result for other second line drugs like fluoroquinolone and kanamycin was lower and similar to that of rifampicin and INHA. So this is, if you can see this figure where we have illustrated the DST on culture molecular methods in highlighted in blue color box, whereas phenotypic DST has highlighted in red color box, and there was the difference. So what we need to note about that is that occurrence of discrepancies between DST performed on midget system and non-wild type molecular assays. Also occurrence of discrepancies between DST performed on liquid versus solid system and molecular assays, and not every genotypic modification of drug resistant associated gene affect phenotypic resistant equally. So there are lots of things which matters. For example, MIC values, silent mutations, breakpoints, level of resistance has and also not every genotypic modification of DR associated genes affect the phenotypic resistance to different drugs of the same class. So here we need to think about the borderline or low level resistant, and that has been strongly associated with the treatment failure, and which may give rise to the resistance for that particular drug. So what we are looking for, so basically we are looking and what are the needs and barriers are here while going for conventional DSTR, understand SNP-DST relationship, and understand SMP critical outcome relationship, and to guide the development of a new molecular diagnostics and new policies. These are the few of the needs. And what are the barriers for that are data set for scattered across a high number of studies. Different studies use different methods, that is some use liquid versus solid culture, some use SMP detection approach. So here the methods and number of samples are less as compared to others. Then few studies correlate SMP versus MICs, where fewer correlate SMPs with clinical outcome. Few studies are on functional genetics and need to include all genes for all the drugs. So we are looking for some fundamental exposure for all the things where we can detect or study the population-based study, where we can say that some of the phenotypic and drugs and the genotypic barrier, whatever we can say for a large group of a patient or cohort. So the need is for TB whole genome sequencing is rapidly shown the exactly affecting MTB, including its complete drug resistant profile, and this allows clinician to identify the best treatment regimen to combat the disease, where we can call it as a personalized or tailored treatment. The implementation of a TB genome sequencing will benefit the NTP providing data for surveillance of resistance to different anti-TB drugs and important information for high burden countries to set TB control strategies and priorities. These are the guidelines which has been published in March 2021, and which says exactly that NGS has a great potential for rapidly diagnosing drug-resistant tuberculosis in diverse clinical reference laboratory settings. So by taking all the considerations above, we at Thyrocare launched TB whole genome sequencing in partnership with Haystack last year. Our lab is with the NTP algorithm. Initially, we have kept this for last year. The pricing was 3,000, now increased to 5,000. And what we are getting here is an 18 antibiotic coverage in just 12 to 15 days of a TAT. And along with that, we are getting other information, that is a straight identification, mixed infection, or there is any co-infection along with the drug-resistant testing. So basically, TGS at our end is designed for scale. So where we can where we can see the safety of the people who are working in the laboratory, which is exactly opposite or safer as compared to the phenotypic DST, where actually we are playing with the culture in the laboratory. We can automate extraction and other things along with other labs for, and we can generate a real-time data and push it to the NICSHA portal if required. So in a nutshell, TGS can provide greater resolution than conventional genotypic for investigating recent TB transmitter or drug resistant. Also, it is a one-stop source of a curated genotypic and related metadata from NPD stains. And we are transitioning using TB whole genome sequencing as a standard method of TB diagnostics by providing antibiogram of 18 drugs within 12 to 15 days and at affordable cost. Thank you.
Thank you, Dr. Chaitali, that for explaining how Thyrocare has come up with an innovative solution, that is TB whole genome sequencing, and also for highlighting what is the need of the hour in terms of generating the data from TB whole genome sequencing and correlating it with the culture DST. So thank you once again. I thank both the speakers, and considering that we have a few minutes left for our Q&A session, I think most of the questions have been answered. There have been a few hands that have been raised, so I will just allow the first person, Mr. Sonu Mishra, to talk. Yes, please, Mr. Mishra, you are unmuted. So would you like to ask? You have raised your hand. Would you like to ask a question? Mr. Mishra, you are unmuted. You can ask. I don't think we can hear you. Mr. Mishra. I don't. We will ask the next. Dr. Ram Kishore has also raised his hand, so I'm going to allow you to talk. Dr. Ram Kishore, please do. You are unmuted. Ranjan, can you please look into it and see if we can, or the training team, can you please unmute Dr. Ram Kishore?
So, Dr. Ram Kishore, you are on mute. Please unmute yourself. To ask the question.
Also, Dr. Aparna, there are a few questions in chat box. Instead of question and answer, they have been given to chat.
Yeah, I just read one question which I would like to answer.
Sure.
This was about TB gold. So basically, we not encourage performing TB gold testing. These are blood-based tests. This may be used in countries where you have latent TB infection. I'm sure of us are aware since 2012 ban antibody testings for tuberculosis. Even IGRA be gold quantiferent TB. It's a costly test, and really it does not give you any more output than Mantoux test, which again we are not doing nowadays. It is only for excluding the diagnosis and not including the diagnosis. So no, do not go for TB gold testings of blood.
Thank you, Dr. Aparna. And I think with that, we will conclude our webinar for today's session. I would like to thank both the speakers, Dr. Aparna Birajdar and Dr. Chaitali Nikam, for giving us such valuable information on the current diagnostic modalities in management of drug-resistant tuberculosis and running us through the entire algorithm in a very lucid manner. Once again, thank you, and we look forward to continued interactions. I would also like to thank all the participants for attending. In case you have any queries, please do reach out to us. We will be sharing the recording as well of this webinar. Thank you. Dr. Aparna, I would just like to add that there have been a lot of messages which have been saying excellent webinar and congratulatory messages have been pouring in. So just to thank you about that as well. With this, I think we can end the webinar. Have a good evening, everybody. Thank you.
Thank you. Thank you so much for giving this opportunity.